Yeah. Okay. So, hi everyone. Welcome to today's Journal Club. My name is Anna Fagotti. I'm an associate editor of the International Journal, and I'd like to thank ESGO and IJGC for their support to our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. If you are having any difficulties or questions, please send a message in chat and our technical support will assist. We will have time for question and answer and encourage you to submit questions via the chat function throughout today's session. So this month's lead article is the Sentinel lymph node detection in early stage ovarian cancer, a systematic review and meta-analysis by Nuria Augusti, and I'm pleased to welcome her to join us. So Nuria, thank you for being with us today and sharing a deeper insight into this great article. I'm going to hand it over to you for a summation of the article. Thank you.
Yeah, hello, everybody. Thank you so much for the invitation. For me, it's a great pleasure to be here with you all. And I hope that we have a great discussion and we can enjoy this subject that I think that it's still really, really new and there's a long pathway ahead. So please feel free to ask questions so we can enjoy most the discussion. So I will share my screen in order to... Okay. Okay. Do you see something? No, not yet. Okay.
Okay.
Okay, now. So, well, I'm Nuria Agustí. I'm now currently doing a postdoctoral fellowship at MD Anderson Cancer Center, but I've done my residency and I've been treating gynecology and oncology in Hospital Clinic of Barcelona. And well, we are going to discuss this monthly article. It's about the sentinel lymph node detection in early stage ovarian cancer. And we're going to talk about the systematic review and meta-analysis. So around 20 to 30% of patients with ovarian cancer are diagnosed with clinically early stage at initial evaluation. So at the moment, a comprehensive staging surgery, including systematic pelvic and parotid lymphadenectomy, remains the standard surgical management of these patients. However, to note, the incidence of lymph node involvement is only about 15 to 20%. So, although it provides us information regarding the prognosis and allows us to adjust adjuvant treatment, performing a lymphadenectomy is an invasive and laborious technique associated with intraoperative and postoperative morbidity, and it finally results in a decrease in the quality of life. So regarding the sentinel lymph node procedure, over the past years, sentinel lymph node mapping in gynecological tumors has emerged as an alternative technique to identify lymph node metastases and be able to, in fact, reduce the surgical morbidity associated with the systematic lymphadenectomies. However, its application in ovarian cancer is more challenging since, for example, the tracer injection technique and the ovarian lymphatic drainage are much more complex. So it is considered a procedure is still under investigation. And at the moment, few studies with a limited number of patients have been published and and there is a high heterogeneity. So I think that there is still a long way ahead. So the primary objective of the study was to evaluate the detection rate and diagnostic accuracy of sentinel lymph nodes in patients with early-stage ovarian cancer. As a secondary objective, we aim to analyze factors related to the sentinel lymph node mapping detection rate, such as the tracers used, the injection site, and the type of surgery. Regarding the methodology, the protocol was registered in Prospero and was conducted according to the PRISMA guidelines, that is, it recommended. Inclusion criteria were studies performing the sentinel lymph node mapping technique in patients diagnosed with early-stage ovarian cancer, and reporting the detection rate and diagnostic accuracy in those who had undergone a full pelvic and para-aortic lymphadenectomy. We excluded patients with benign ovarian pathology and also with borderline tumors. We then conducted a systematic review and meta-analysis, and we also evaluated the risk of bias using the QUADAS tool. Finally, 9 articles were included, of which 6 were observationals and 3 were clinical trials. And a total of 113 patients were included in the final analysis. So regarding the results, the overall sentinel lymph node detection rate was 93.3%, and the negative predictive value was 100%. Regarding the secondary outcomes, the sentinel lymph node detection in relation to the tracers used, the combination of radiotracer and ICG showed the highest detection rate at 100%, and the combination had the narrowest confidence interval. Injection with the massive zero also showed the best outcomes with a 98.9% detection rate. And finally, in relation to the injection site, both ovarian ligaments showed the best detection rates. So this is what I had prepared for you as a summary.
Thank you very much for this summary, Nuria. We will now spend the remaining time on answering questions and group discussion. Attendees, we encourage you to submit questions via the chat function, and we will do our best to address as many as possible. We are going to start out with some questions by our fellows, and the first one is Seda. So please, Seda, go on.
Thank you for your good presentation. I want to ask that what is the optimal injection site for the sentinel lymph node detection, and from where to start the evaluation, the sentinel lymph node first, the pelvic area or the para-aortic area firstly?
Yeah. Thank you, Sarah, for this question. In fact, when considering the injection site for sentinel lymph node mapping, there is fortunately a high level of agreement among the studies that we reviewed, and the results show that both ovarian ligaments, this is infundibulopelvic and uterovarian ligaments, were, by large, in fact, the most commonly used injection site, and it was employed in around 92-93% of patients. It's true that I just want to go through it quickly. There was just one study that injected the tracer into the cortex. However, it was in less than 5 patients. And this practice was abandoned when sentinel lymph node mapping was just starting to be investigated, because to note it was considered risky due to the peritoneal potential for tumor spillage and dissemination through the pelvic abdominal cavity. Regarding your second point, I think that, from where to start the evaluation, I think that it is indeed a significant matter that it happens in real practice. So unfortunately, this question cannot be answered based on the evidence, since none of the studies reported it specifically in their methodology. But from my personal point of view, my own opinion, I think that the choice on when to start the evaluation, it can depend also on the type of the tracer used. So really quickly, for example, radiotracer, it has like a large molecular size, and it tends to get trapped in the first lymph node for a long period of time. So it might allow surgeons to apply more flexibility, and they can start from wherever they might feel more comfortable. However, when using the ICG tracer, then the cyan in green, as it has a smaller molecular size, this tracer tends to rapid migrate through the lymphatic nodes. So it's important because, as we already have learned from other tumors, I mean, if there is a significant delay from the time of the ICG is injected and the time that we do the sentinel lymph node detection, this can make identifying the first sentinel lymph node more challenging. And well, this is because, as I mentioned, the ICG might have already spread beyond the first sentinel lymph node by the time that you decide to proceed with the detection. So with ICG, I think that it's really important to have like the entire surgical file ready, including the aortic region, and prepared to waste the minimum time until detecting the sentinel lymph node. Another viable option that maybe one could explore in case of also using the ICG, maybe it would be to inject the tracer in 2 times. For example, you can inject first the tracer into the fundibulopelvic ligament and start evaluating the aortic region. And in a second stage, inject into the uterovarian ligament and continue with the corresponding pelvic file.
Yes, I completely agree. Thank you very much, Nuria. I think this is really important. Said, I think you have another question, so maybe you want to continue with Nuria.
Thank you. As stated in the discussion section, retroperitoneal pelvic extravasation when injection, the tracer may be a problem. Which could be the best way to do the injection in order to have good results and to avoid these kind of issues?
Yeah. Thank you again, Sada. Yeah, I think that it's something that, again, it's not reported in the literature, and the answer is based on my personal perspective. But first of all, I think that it's really important to highlight that ovarian cancer, unlike other tumors such as vulva, cervix, or endometrium, one concern that we cannot modify is the fact that the ovary is located inside the abdominal cavity, and specifically in the same surgical file where pelvic lymph nodes are located. So why is this important? Because it means that there is an inherent risk of contaminating the pelvic surgical file only because the tracer needs to be performed in the same location where the ovary is. So, for example, to better understand it, and I want you to give some numbers from our systematic review, we observed that in less than half of the patients, pelvic lymph nodes were detected. And in contrast, approximately around 90% of patients, an aortic sentinel lymph node was observed. So there was a difference of 40% of detection rates between the 2 regions. So if you ask for some tips and tricks to minimize the leakage chances in the surgical practice, I would suggest, first of all, before injecting, maybe wrapping the injection site with a surgical gas and keep an aspirator at hand in case any extravasation is observed. And right after, once the tracer has gone through the needle and you retrieve the needle, coagulate the injection points to seal the peritoneum in case that any minor injuries have been performed. However, as the injection is performed in a thin layer of peritoneum rather than dense tissue, as it occurs in cervix or endometrium, if the tumor is really, or it was to be after the nexectomy, really adhere to the peritoneum, and I mean, you needed to do a huge dissection of the peritoneum, I think that, again, there is an inherent risk of leakage that we cannot modify. So, in my opinion, the less manipulation, the better the chances of avoiding maybe significant leakage.
Thank you, Nuria. I think that based on this discussion, we could introduce also a question from the audience. I see here Victor Lago is connected. He is quite an expert in this field. So the question from him, maybe Victor, I don't know if you want to say it by yourself if you are online. I don't know. I can. Okay, good.
Hello, thank you for your introduction. I don't know if you can hear me accurately.
Yes, very well, thanks.
Okay, very nice discussion. I'm very enthusiastic with this topic. And I would like to ask you both, in your experience, in your centers, to Dr. Fagotti and Dr. Agusti, which is, under your point of view, the needed learning curve to rise and expertise in this technique? Thank you.
Please, Nuria.
Okay, thank you. Yes, thank you, Dr. Lago, for this interesting and I think important question. As I mentioned in the slides, I think that ovarian cancer, the sentinel lymph node technique, it's more challenging than the other ones. And this is because the injection site, it's done intraoperatively and in the same surgical file. So I think that the learning curve in this case, it's super needed because it's not like in the cervical cancer and endometrial cancer that you inject it into the cervix. And so we already have gained experience. From our point of view, in Hospital Clínico Barcelona, before performing the Melissa trial, we've performed around between 7 to 10 pilot cases just to learn the technique. And in fact, during these cases, we learned some red flags and we had to modify it before starting to enrolling the patients officially. So I don't know how many patients we might need, but what I'm sure that we might need some pilot patients if a center wants to start this technique, because this is a really different one and we don't have experience. So for the first case, I think that we need still to learn without enrolling them in a study. I don't know, Dr. Fagoti, what is your opinion?
More or less the same. I mean, we have had problems at the beginning because of this leakage and the contamination of the field. So we have learned over the time. And I see, Victor, you also are having a nice technique. Maybe you can also advise people about your approach.
Well, my experience is about that in our center, we conducted a pilot study. I performed all the cases, and in the clinical trial, I also performed all the cases. So I improved my results from the pilot study to the clinical trials. The main concern is about the pelvic migration. I read with a very big interest the article from Stefano Uccella, in which he compared the injection of two tracers in two different points in order to elucidate if the migration from the cervix and from the uterovarian ligament goes to the same lymph node. And I think, under my point of view, that this is the key question about the implementation of this technique. So now in our center, we are conducting a validation of this study that it's, from my point of view, the most important about all the aspects related with the technique, because we as gynecologic oncologists are used to perform the sentinel lymph node, injecting the tracer into the cervix. So the simplest, the better. I think that this step, in order to elucidate which is the best site of injection, will promote or not the technique of sentinel lymph node in ovarian cancer.
Thank you very much. And I think this, I mean, we are going through questions and there is another question from the fellows, which is very connected with your comment. This is from Jessica, I think. Are you connected, Jessica? I can see you.
Yes.
Okay.
Yes, I'm here.
Okay. Would you like to ask a question to Nuria? Thank you.
Thank you, Dr. Augusti, for your kind presentation. We have right now mentioned the article of Professor Uccella, and my question is about it. The authors described the cervical injection as a more feasible alternative for sentinel node mapping in ovarian cancer compared with the classical proper ovarian ligament injection. So I want to think, what do you think about it? And does two different approaches get the same migration pathways, in your opinion?
Yeah, thank you, Jessica, and thank you, Dr. Lago, because indeed I completely agree with what Dr. Lago mentioned. As I previously also mentioned, in the systematic review, the pelvic detention rates were much lower than the aortic ones, being the aortic detention rates almost doubled compared to the pelvic one. So I think that there is just something that regarding the pelvic detection rates, we are failing to detect. So interestingly, to overcome this problem, there is a study from an Italian group that in order to enhance the pelvic sentinel lymph node rates, they explore the concordance between two thoroughly distinct lymphatic pathways by performing in the same patient an injection with ICC to the cervix and an injection with blue dye to the uterovarian ligament. So what is super interesting is they consistently identify the same pelvic sentinel lymph node in all the cases with both tracers. What means that the indocyanine green injected into the cervix reached the same sentinel lymph node as it did the blue dye, suggesting that the two injection sites may be equivalent. However, to note that I think it's important to highlight the cervical injection would not replace the injection into the infundibulopelvic ligament, since the ovarian ligament contains the ovarian vessels and provides the lymphatic pathways to the aortic region. So I think that it's really interesting that it deserves more exploration in further studies. And for me, it's like it shares similarities what it is happened with endometrial cancer in the beginning, because if you recall, initially there were trials exploring tracers injections into endometrium closer to the tumor site because it was like more accurate and based on the understanding that direct running to the aortic region was like the more accurate one. However, it has been proven that injecting into the cervix is much simpler and the risk of skin metastasis remains low. So, well, theory does not always align with the practical and pragmatic techniques. And yeah, I think that in light of this, I believe it should, at least it deserves to be still investigated because, as Lago said, the simplest, the best, and the simplest, the most broadly applicable approach.
Thank you, Nuria. Thank you very much. I think we should also consider what is the rate of lymph nodal metastasis usually with a systematic lymphadenectomy in the aortic and the pelvic area. So we do expect to have more metastatic lymph nodes in the aortic area. So this is our main goal anyway, which is different from any uterine cancer. So I see there are questions coming from everywhere, so I don't know how to manage it. Maybe Giuseppe first, Giuseppe Cucinella, another fellow. Would you like to make your question first?
Hi, everyone. And first of all, I want to thank Dr. Fagotti for the introduction, Dr. Augusti for the great article, and thank you for your time here. My question is about possible reason for failure of sentinel lymph node mapping. We have already touched some of this point, but my question is, do you think that the reason may be the same as those shown for the other cancers? So we already know what are the reasons for failure in endometrial cancer. So do you think are the same or there are other reasons for failing? Thank you.
Yeah, thank you, Giuseppe. Yeah, I think this is an interesting question, but unfortunately, we still need to standardize the technique. And when there is a failure in sentinel lymph node identification in ovarian cancer patients, it may not be clear whether it's maybe due to the applied technique or maybe to do other factors. However, I believe that ovarian cancer presents unique characteristics, and the reasons for sentinel lymph node failure may also differ compared to other cancers. For example, in other tumor sites, it has been suggested that reinjections of tracers can be beneficial or can improve or enhance the sentinel lymph node detection rates. But when it comes to ovarian cancer, the decision to reinject the tracer would depend, from my personal opinion, to the extent of the dissection performed during the annexectomy. So imagine the annexectomy was performed, resulting in a significant tissue disruption due to tumor adhesions or whatever. So I think that in this case, reinjecting the tracer might not be recommended, unlike it happens in other tumor sites such as endometrium or cervix. So I also think that other factors that have not yet been explored can also play an important role, such as endometriosis. I think that maybe it might also interfere with sentinel lymph node detection. following the same rationale that there are a lot of adhesions, and so you have to disrupt the peritoneum tissue and so on. So, well, I think that we should be really cautious when considering the injection of larger volumes, as there is an inherent elevated risk of extravasation, just because we're injecting, as I have mentioned, in a thin peritoneal layer. So the risk is increased in ovarian cancer.
Okay, thank you very much. So we have now a question from Indonesia, National Cancer Institute. Dr. Veinardi, are you connected? Would you like to make your question?
Yes, yeah. Hello, everyone. Thank you. Well, I come late, so maybe my question is a little bit common. I would like to ask about the technique. So many cases came to our center after oophorectomy. So can it be done to the the IP ligament? Can we inject it, or we cannot inject it, and we have to perform the other way? Yeah, thank you.
Yeah, I think that it is a really pertinent question. I think that you are referring to restaging ovarian surgeries, right?
Yes.
Okay, yeah. Well, I mean, it can be done, and it has been described in the literature. In fact, we also report this technique in restaging surgeries in our review, but we have encountered discrepancies in the literature, since in the systematic review, detection rates from Dr. Lago and their colleagues were excellent, even in restaging surgeries. However, in the preliminary results of the SELI that has been already published some years ago, showed more discouraging outcomes. So I think that further studies would be needed to elucidate this concern. However, again, from my personal point of view, I don't believe that performing the injection in the stem of the ovarian ligament, it's a problem. I think that the real concern lies in the fact that due to a previous surgery, there is an increased risk of adhesions in the pelvic area where the ovary was previously located. And this is what I think that can potentially decrease the detection rates. The fibrosis created between the first surgery, some weeks before, and the moment that you decide to perform the restaging surgery. So for me, it would be the main concern.
Okay, so I see now there is a question that is the same question from the fellow and also from Dr. Bella Ugeli from Georgia. So maybe Matt, would you like to make your question, and maybe then we can see whether Bella is happy with the answer, or maybe she wants to add additional comments. Matt, are you online?
I think Professor is not online, so.
Okay, so
if
maybe
you want,
Giuseppe.
I can ask the question.
Okay, thank you very much, Giuseppe.
Yeah, because I've seen there's the same question, and it's basically about non-high-grade serous ovarian cancer. And so the question is, since the majority of patients included in this analysis have high-grade serous ovarian cancer, how do you think these results can be implemented in other histotypes, such as mucinous ovarian cancer, which have different degrees of lymph node involvement?
Yeah, thank you, Giuseppe. Wes, unfortunately, in our review, the sample size was too small to conduct a sub-analysis to identify any differences among the different histological subtypes, so we cannot have an answer. But what I can say is that it's true that, as we all might acknowledge, there are certain epithelial histologies that where we might consider not using the sentinel lymph node technique, but not only for sentinel lymph node mapping, but also for lymph node staging in general, given that lymph node involvement rates are lower than 5%. So it's important to differentiate and to emphasize that this likelihood depends on the histology of the ovarian cancer. And for example, low-grade endometrioid or expansive mucinous ovarian cancer typically have a lymph node involvement rate lower than 5%. but instead low-grade serous ovarian cancer and, of course, the high-grade histologies often presents with lymph node metastasis rate exceeding 10% or 15%. So these later groups with this higher rate of involvement nodes would justify maybe the lymph node assessment, as we also do for other gynecological cancers with similar risk rates of lymph node involvement. While the other groups with so many small rate of lymph node involvements, I think that maybe it wouldn't justify neither the sentinel lymph node, neither the staging in general.
Thank you, Nuria. Maybe we can also comment the fact that if we think that this is simply an anatomical evaluation or diffusion, then there shouldn't be any difference from the detection rate according to different histologies. So I would not expect a different detection rate according to different histologies, just because I'm trying to find the sentinel nodes. But actually, I agree with you that maybe it's not justified. Yes. So, Bella, I see that you are happy with this answer, isn't it? Okay, so the next question from Luigi.
Hi, Nuria. So thank you for the amazing presentation and article. My first question, thank you, has been already done by Dr. Veinardi, so I will skip it. But I have another question related to research on this topic. And so if you were designing a study to evaluate the performance of sentinel lymph node in ovarian cancer, what procedure would you use? I don't know, do you have some tips on timing and site of injection and tracer? What's your perfect trial for you?
Yeah, thank you. Thank you, Luigi. First of all, I think that it's, again, important to highlight that in this review, there were a substantial heterogeneity observed among all the studies. So there were also low number of patients included and limited statistical power to detect significant differences between the techniques. So I think that we have to keep it in mind. But if we want to stick to the results of the review, what we saw and what I would recommend for sure is that for further trials, the injection should be performed to the uterovarian and infundulopelvic ligaments using andocyanin ring. And you can also consider, based on these results, adding a second tracer, such as the radio tracers. It can increase sentinel lymph node detection rate. However, our results were not significantly, statistically significant, sorry. But from my point of view, if we want to be pragmatic, I think that from the published studies and ongoing trials, at least it's becoming clearer where to the injection site should be ideally performed, as I have mentioned the ovarian ligaments. But when deciding the best moment to perform the injection, this is, I think, another issue that we could discuss. I think that one thing is the optimal scenario, and the other thing is the reality. What most of us would agree is the optimal scenario maybe would be performing it without the mass. Why? Because, after the nexectomy. Because this way we would avoid unnecessary injections if the frozen section turns out to be non-malignant. And finally, when deciding which tracer use, I think that the ideal scenario, also most of us would agree, that it would be using only andocyanin ring, since it depends only on the gynecologic oncologist, and we already have more experience in the other tumor sites. However, again, I'm not sure if it's the reality, because the current results of the systematic review do not align with what we might expect to be like the ideal approach. So at least based on our results, considering the addition of a second tracer due to the characteristics maybe of ICG, could be recommendable. And alternatively, in order to enhance the pelvic sentinel lymph node detection, I just, again, to remind that exploring another injection site in, for example, the cervix one, would be also super interesting to explore for future studies.
Thank you.
Thank you. Thank you, Nuria. Before continuing with the fellows, I see Nicola Bizzarri is also connected and he has another question. Maybe, Nico, would you like to ask directly.
Thank you, Anna, for the opportunity to give the question, and congratulations, Nuria, and all the colleagues for the article. Really, really interesting. Now, I want to, before doing the question, to comment about, because in our experience, I agree, it's not a very reproducible technique, and in a multi-center setting, we need to consider that the detection rate could be lowered by the experience of the surgeon. Having said this, from my point of view, the best scenario, as you mentioned, Nuria, could be with before removing the mass, to inject the infundibulopelvic pelvic ligament, because with a naive peritoneum, everything is different. This is our experience. And of course, as you mentioned, from the experience of Stefano Uccella, the cervical injection could be an alternative. So this could be the ideal scenario. Having said that, my question was about the surgical approach, and I was wondering whether you found a difference in detection rate in open versus minimal invasive approach to do the sentinel lymph node technique. Thank you very much, and congratulations again.
Thank you, Nicolo, for your opinion and also for the question. Yeah, in the review, we did not compare the different surgical approaches, but we, at the beginning, before publishing it, we started to explore this comparison, and we found that there were not significant differences, but there were like an heterogeneous sample size, and I think that in the review were like 4 studies were using minimal invasion approach, and 5 studies were using open approach. We did not officially publish it, but back in the sense we went through it, and we did not find any differences. But we did not find any differences among any of the objectives that we went through. So probably because the sample size was also small. But answering to your question, we did not find that the surgical approach might have any impact on the results.
Thank you very much. Thanks.
Thank you. Wonderful. So, Giuseppe, your question.
Yes. Yeah, my question, I think, is a little bit different, and I want to talk about also the medical treatment and the implications that sentinel lymph node can have, because I know that the therapeutic role of systematic lymphadenectomy is somehow controversial and associated with potentially serious complications, and so I see that it's interesting to see if sentinel lymph node can be a safe alternative. But I also think that ovarian cancer is a different setting than probably endometrial and cervical cancer. And this is because here we have also the maintenance therapies. And we know that the access for these important therapies is only restricted to advanced stages. And so I thought that, I don't know, in the era of targeted therapies, the systematic lymphadenectomy can also be of paramount importance to identify advanced stages due to lymph node involvement that could benefit from these maintenance therapies. And so my question is, based on the review that you did, can we really trust the sentinel lymph node without risking of missing a great opportunity for these patients? And we know, of course, the survival benefit associated with PARP inhibitors.
Yeah, thank you, Giuseppe. I think that this is the future, and it's, I mean, the fact that finding these sentinel lymph nodes has been involved, I think that it's really important because it will allow us, as you said, to give patients maintenance therapy. Unfortunately, I think that if I want to be consistent with OIMAR relates during the journal, I think that we still cannot fully rely on sentinel lymph node mapping. We are, I think, still exploring this technique. It's under investigation, and larger studies are needed in terms of evaluating the sensitivity and false negative rates. I think that upcoming results will be from Sally's study, the one of the larger ones. But what I think, it's super important, is that doing and still seeking to know the lymph node involvement rate, I think it will help us to provide patients with maintenance therapies such as bevacizumab, or if they have BRCA mutation, patients with will be able to benefit from IPAR therapy. And I think that not only maintenance therapy, but knowing the sentinel lymph node status would also enable us to tailor the adjuvant treatment by adjusting, for example, the numbers of cycles or the combinations of chemotherapies. And it would also allow us to reduce morbidity in this sense, not only the surgical one. And additionally, I think that we haven't gone through the ultra staging, but also doing the sentinel lymph node technique. If we in a future we can learn more about what we are doing and the diagnostic accuracy it's enough good, I think it will be also really beneficial, because we will be able to investigate the micrometastases, the isolated tumor cells, so that low volume metastasis, and it will be a new landscape that we are just starting to investigate, and maybe would allow us to know which patients are at higher risk of relapse, patients that maybe now we don't know why they are relapsing, and we could anticipate to this, and we could give them maintenance therapy and maybe improve or enhance the survival outcomes.
Thank you, Nuria. I think this is a very important comment, both from Giuseppe and yourself. And indeed, the ITC that we have discovered during the conduction of the trial, then we really don't know how to manage them. Are these really positive nodes, or are simply transient cells? And maybe liquid biopsy can, take the place of any kind of lymphadenectomy, just because we know that there are cells around in these patients. I see Nico had the hands on, or isn't it?
No, I was impressed by the discussion, and I really wanted to comment about ultrastaging. Manuria already did, because ultrastaging is an opportunity for the patients, now for all gynecologic oncology patients. So I really believe in the benefit of ultrastage one node, and this in ovarian cancer can make a big difference for the maintenance therapy. So thank you, but already Nuria mentioned it, so thanks.
Yeah, I think it's really interesting, and also in hospital clinic in the Melissa trial we found like some patients with low volume metastases, and now we are just learning, okay, how can we interpret these results? We don't know, but maybe they are higher risk patients that we were not able to detect it previously, and now we have this tool, and maybe now we could focus more on these patients and anticipate, with other therapies that are coming up.
Yes, indeed. Actually, in our case here in Rome, she was a grade 3, high-grade serous ovarian cancer. So she was already an high-risk patient, but then she had ITC. So would you give maintenance to these patients or not? I really don't know if it's beneficial or not, and maybe it's based also on the HRD status that at that time we didn't know. I have some, if there are no questions from the audience or from any one of you, and please feel free to raise your hand if you want. I have a question. Maybe this information was not available from the study, but do you have any data on empty nodes in these patients?
Yeah, in the study, all the articles that we included, they did not discuss regarding the empty fatty nodes. And in fact, the reference standard was a full lymphadenectomy. So all the sentinel lymph nodes that were detected, they were histologically analyzed, and they were not empty fatty nodes. But what is true is that using ACG and with the additional problem that we are facing, that is the extravasation, I think that we are facing a new problem, a problem that we are not having at least at the same degree of level with the other cancer sites, and it's the empty fatty nodes, because of course, if the ICG, for example, extravasates through the fatty tissue and through the pelvis, so it becomes really difficult for you to detect the real sentinel lymph node. So maybe a new landscape, it's ahead, and maybe frozen section to just make sure that there's a real sentinel lymph node and not fatty tissue will be more important in these patients compared to the other gynecological tumors. So I think that it's also, everything is very new, but it's very interesting what you bring up here, because there's a higher risk, of course, using mostly the ICG. So I agree.
Yeah. So I see another question from India now, from Dr. Dania Dinesh. Are you connected, Dr. Dinesh? Would you like to make your question live? Or I can do it for you as you want.
Hi. Yes, I'm connected. Thank you. Very interesting discussion. Thank you for the great discussion. I just wanted to put the question like, what was the average time that you noticed between injection of the tracer and detection of the sentinel node?
Yeah, thank you, Dania. It depends on the tracer that you decide to use. As the molecular size of the radiotracer, as I previously mentioned, it's larger, the radiotracer becomes trapped in the first sentinel lymph node. It needs some time until it gets trapped in the first sentinel lymph node. And the studies allow at least 10 to 15 minutes until starting the detection. So the radiotracer needs more time. Instead, the ICG, it's something that we already know with the other gynecological tumor sites. It's something that it's almost immediate. So it's like you have to inject it and you have to have prepared all the surgical site, the aortic one, the pelvic one, and you have to be ready once you have performed the injection to start the dissection and the sentinel lymph node detection. So to sum up, with radiotracer, we have to wait like at least 10, 15 minutes. With ICG, there's no need to wait until starting the detection.
Thank you very much, Nuria. Actually, there are additional questions that I would like to do to you, but we don't have time anymore. So I want to thank you very much for this very important study that you made. I think it opened, the field for additional research, which is very important to look at the problem in a very critical way. So looking forward for the results of the new studies. I want to thank all the fellows also. And I hope you enjoyed your time with us today. And I want to thank also all the attendees for their participation. And the recording to today's session will be available on the International Journal Gynecological Cancer, IJGC and ESGO website. And don't forget to participate to the next journal club, which will be on Monday and on the new FIGO classification for endometrial cancer. So see you very soon, next days. Thank you very much, everybody. Bye-bye. Thanks a lot.
Bye-bye. Thank you very much for joining us. Bye-bye.
Bye. Bye.
Bye.
Bye.